Hello everyone, and welcome to the second session under Chapter 17, Patient Assessment, entitled Assessing Perfusion. As always, this is Keith Widmeyer with Wayne County EMS. Let's go ahead and get started. While assessing the patient's pulse, quickly check the patient's skin. Assessment of the patient's skin condition can provide important information about the flow of blood through the body's tissue, termed perfusion. Perfusion is assessed by evaluating. Well, what are we going to evaluate? We're going to evaluate skin color, skin temperature, skin moisture, and capillary refills. When we are assessing skin color, we want it to be pink. Colors that it may potentially be include blue, which is cyanotic, maybe gray or ashen. It may be pale, which is white. Skin temperature. We want it to be warm. It could be hot, which is not what we're looking for. It could be very cool, which is not what we're looking for. And moisture. We generally want it to be dry. However, it may be very diaphoretic, which is moist, sweaty. And capillary refills. In infants and children younger than 6 years of age are an excellent indicator, but are beneficial in adults as well. When we assess capillary refills, we just pinch a fingernail and until it becomes kind of a whitish tinge. Then we let go and wait until count how many seconds it takes before it comes back to being pink. Okay, let's see. Assess the patient's skin color in the nail beds inside the mouth and inside the eyelids. In infants and children, assess the palms of the hands, soles of the feet. Pale, whitish skin color occurs when blood vessels in the skin have severely narrowed. This condition may be seen in shock, fright, or anxiety, and with other causes. Cyanosis, or bluish-grayish skin or mucous membrane, suggests inadequate breathing or poor perfusion and often appears first in the fingertips and around the mouth. You may also see it around the eyes and the orbits. Cyanosis may be seen in respiratory distress, airway obstructions, cold exposure, blood vessel disease, shock, and cardiac arrest. Mottling refers to irregular or patchy discoloration of the skin that is usually a mixture of blue and white. Mottled skin is usually seen in patients in shock with hypothermia or in cardiac arrest. Jaundice, which is yellow skin, may be seen in patients with liver or gallbladder problems. Flushed or red skin may be caused by heat exposure, late stages of carbon monoxide poisoning, allergic reactions, alcohol abuse, or high blood pressure. Assess skin temperature by placing the back of your hand against the patient's face, neck, or abdomen. Normal skin temperature is warm. Hot skin may be caused by fever or heat exposure. Cool skin may be caused by inadequate circulation or exposure to cold. Cold skin may be caused by, an extreme exposure to cold or shock. Clammy or diaphoretic skin, which is cool and moist, may be caused by shock, among other conditions. Assess the moisture of the patient's skin. Normal skin is dry. Wet or moist skin indicates shock, a heat-related illness, or diabetic emergency, among other things. Excessively dry skin may indicate dehydration. Assessing capillary refills in an infant and children less than 6 years of age. To assess capillary refills, firmly press on the child's nail bed until it blanches, which means turn white and then release. Observe the time it takes for the tissue to return to its original color. If the temperature of the environment is warm, color should return within 2 seconds. Other sites may be used to assess capillary refills, including the forehead, chest, abdomen, and fleshy parts of the palm. A capillary refill time of 3 to 5 seconds is said to be delayed. This may indicate poor perfusion or exposure to cold temperatures. Capillary refill time of more than 5 seconds is said to be markedly delayed and suggests shock. When assessing this in adults, it's important to keep in mind underlying illnesses such as peripheral vascular disease and other circulation disorders. Examine the patient's pupils. Pupils are normally equal in size, round, and equally reactive to light. Briefly shine a light into the patient's eyes and assess size, equality, and reactivity. When we're assessing size, dilated, which means very big, pupils in the presence of bright light may be caused by trauma, fright, poisoning, eye medications, or glaucoma. Constricted or very small pupils in a darkened area may be caused by narcotics, treatment with eye drops, or a nervous system problem. Equality. Unequal pupils, a condition called aniscoria, are a normal finding in 2 to 4% of the population. In most patients, unequal pupils suggest a head injury or a stroke, the presence of an artificial eye, or a cataract surgery in one eye. Reactivity refers to whether or not the pupils change in response to light. Normally, a light that is shined into the pupil of one eye will cause the pupils of both eyes to constrict. Non-reactive pupils do not change when exposed to light. This condition occurs because of medications or cardiac arrest. In unequally reactive pupils, one pupil reacts but the other one does not, may occur because of a head injury or stroke. Blood pressure is the force exerted by the blood on the walls of the arteries. Blood pressure is usually assessed by using a blood pressure cuff and a stethoscope. This method of taking blood pressure is called blood pressure by auscultation because it involves the use of a stethoscope. When a blood pressure cuff is applied to a patient's arm and inflated, blood flow in the artery under the cuff is momentarily cut off. If a stethoscope is applied over the artery, sounds can be heard that reflect the patient's blood pressure. As the cuff is slowly deflated, blood flow resumes through the partially compressed artery. The first sound you hear is the systolic pressure. Systolic pressure is the pressure in an artery when the heart is pumping blood. As the pressure in the cuff continues to drop, a point is reached where sounds are no longer audible because the artery is no longer compressed. This is the diastolic pressure. Diastolic pressure is the pressure in an artery when the heart is at rest. A blood pressure measurement is made up of both systolic and diastolic pressures. If it is written as a fraction, for example 116/78, the systolic number is the numerator or the top number, and the diastolic number is the denominator or the bottom number. One way that I remember it, systolic is when the heart is contracting, so systolic squeeze. A stethoscope is used to listen to body sounds. It consists of 4 major parts: the chest piece, tubing, binaurals, and earpieces. The earpieces should fit snugly but comfortably into the ears. For the best sound reception, the earpieces should normally point toward the EMT's face as the stethoscope is put on. The earpieces should be cleaned before and after use. The binaural is the metal piece of the stethoscope that connects the earpieces to the plastic or rubber tubing. When you are using the stethoscope, binaurals should be angled so the earpieces remain in the ears without causing discomfort. The stethoscope plastic or rubber tubing should be flexible and about 12 to 18 inches in length. The longer tubing decreases sound wave transmission. Chest pieces of the stethoscope may consist of a diaphragm and/or a bell. The diaphragm is the circular, flat part of the end of the tubing. It has a thin plastic disc at the end. The diaphragm is used to detect high-pitched sounds, such as breath sounds. The diaphragm should be firmly held against the patient's skin with the fingertips of the index and middle finger. Some stethoscopes are also equipped with a bell. The bell has a deep, hollow cup-like shape. It is used to detect low-pitched sounds, such as those heard during blood pressure measurements. The bell should be lightly held against the patient's skin, just enough to form a seal. When possible, the stethoscope should be placed directly on the patient's skin because clothing makes sounds harder to hear. When auscultating blood pressure, we'll start out with step 1. expose the patient's upper arm. Select the correct size of blood pressure cuff for the patient. Wrap the pressure cuff evenly around the patient's upper arm, at least 1 inch above the elbow. Place the arrow on the cuff over the patient's brachial artery. Step 2. Locate the patient's radial artery. Rapidly inflate the cuff until you can no longer feel a radial pulse. Inflate the cuff 30 millimeters of mercury beyond that point. Step 3. Place the stethoscope in your ears. Place the diaphragm of the stethoscope over the brachial artery and hold it in place. Step 4. While watching the gauge, deflate the cuff slowly and evenly at a rate of 2 to 3 meters of mercury per second. Listen for sounds. The first sound is the systolic pressure and should be near the point where the radial pulse disappeared. Step 5. Continue to deflate the cuff, noting the point at which the sounds disappear. This is the diastolic pressure. Deflate the cuff completely and record the blood pressure as systolic over diastolic pressure. Next, we're going to go over the palpation method. Step 1. Expose the patient's upper arm. Select the correct size of blood pressure cuff. Wrap the pressure cuff evenly around the patient's arm, at least 1 inch above the elbow. Place the arrow of the cuff around the patient's brachial artery. Step 2. Locate the patient's radial artery. Rapidly inflate the cuff until you can no longer feel a radial pulse, and inflate the cuff 30 millimeters of mercury beyond the point at which you last felt the pulse. Step 3. While watching the gauge, deflate the cuff slowly and evenly at a rate of 2 to 3 millimeters of mercury per second. Note the point on the gauge when you feel a return of the radial pulse. This is the systolic pressure and should be near the point where the radial pulse disappeared. The diastolic pressure cannot be accurately measured by palpation. Therefore, when you document this, you will document it, first you deflate the cuff completely, and then you record the blood pressure as systolic pressure over P. P meaning palpate. Normal blood pressures at rest vary according to patient's age. Newborns, the systolic should be 74 to 100 with a diastolic of 50 to 68. Infants, systolic of 84 to 106 with a diastolic of 56 to 70. Toddlers, systolic of 98 over 106 with a diastolic of 50 over 70. Preschoolers, systolic of 98 to 112 with a diastolic of 64 to 70. School-aged children, a systolic of 104 to 124 with a diastolic of 64 to 80. Adolescents, systolic of 118 to 132 with a diastolic of 70 to 82. And adults, systolic of 100 to 120 with a diastolic of 60 to 79. I actually think those are reversed, but honestly, it'll vary. You just will vary textbook by textbook. One thing to consider though, when auscultating or palpating, it is difficult to assess that blood pressure, systolic blood pressure lower than 60. Key points: unstable patients should be assessed every 5 minutes, and stable patients should be assessed and have their vitals recorded every 15 minutes. Remember, a stable patient can become unstable extremely quickly, so reassess frequently. Alright, that is the end of the Assessing Perfusion section of Chapter 17, Patient Assessment.